Hello everyone, my name is Jacinta Smith, and on behalf of the PCPCC Support and Alignment Network, I want to welcome you to today's webinar on Community Integrated Health and Practices. There are a few housekeeping rules I want to go over before we begin. We have a very informative webinar planned for you today, so please be sure to share your comments and questions in the question panel throughout the presentation. We will also answer questions at the very end of the webinar. Today's webinar is being recorded and will be made available on our website 24 hours after the live event. You'll be able to access the recording and presentation slides on this site by tomorrow. So now I would like to introduce our guest speakers for the afternoon. We will first hear from Tig McNeil, who is the Director of Clinical Integration at the YMCA of the USA. Sally Sundar, also from the YMCA Association of Greater Seattle, and Van Chowdhury from the University of Washington Medicine have also joined us today and will share their story of effective community partnership. Thank you again for joining us, and I will turn the presentation over to Tim at this time.
Thank you, Jacinta. So today's objectives for the webinar is to provide an overview of the potential role that community-based organizations such as YMCAs that are prolific across the country and how they can serve as part of an overall comprehensive population health strategy to really supporting physicians, medical practices, and other providers with really implementing various aspects of health reform as they transform the way they conduct medicine, and discuss the steps to implementation for a sustainable clinical integration strategy between a practice that's undergoing transformation and community-based organizations such as the Y, and then look at potential actionable steps, and then really highlighting a successful spotlight that we've that has joined us, which is the group in Seattle. So the impact of health reform, as health reform efforts begin shifting to financial incentives from fee-for-service to health outcomes, then everyone's really looking at how practices can transform to come up to meet these requirements. So things that are really impacting practices such as medical loss ratio requirements, value-based payment, alternative payment models, all of those things really require a progressive population health strategy, and that's why we're delighted to be joined by two people that have really been on the ground implementing population health and can talk to the successes that they've achieved in working continuously to achieve these better outcomes. And best practices in population health really align health systems and practices with community-based organizations so that we can really begin extending the reach of health outside of the four walls of the clinic practice and really begin impacting lifestyle changes and community impacts that may be altering health outcomes. So we've begun to the work that YUSA has done in supporting WISE has really been looking at clinical pathways where YMCAs and other community-based organizations become an extension, becoming embedded into the clinical pathway such that we're able to fully implement primary, secondary, and tertiary prevention because that's really really essential to successful performance around improving quality measures and reducing costs. And community-based preventive efforts have been proven to show that those things can help improve the ability of consumers to improve their own ability to self-manage disease and work towards achieving those goals. And that can ultimately lead to improve MIPS measures, merit incentive payment system, as well as alternative payment measure performance, and as well as cost containment. So this slide outlines the clinical integration roadmap. So from the practice level, if a practice is looking and working towards transformation, looking at the MIPS and alternative quality measures that they have, identifying pockets and segments of the population that they're not able to reach, then they may be looking and thinking about how they could enhance their population health strategy in the most cost-effective manner by leveraging community-based organizations. And that would begin with developing an overall clinical integration strategy, identifying referrals to organizations such as the Y that can deliver evidence-based preventive health strategies and programs, identifying ways to share outcomes, have direct bidirectional referrals, as well as feedback from community-based organizations upon receiving those referrals so that the providers can see and track performance and outcomes. And since, at least from the Y's perspective, the vast majority of the programs we deliver are evidence-based programs that have undergone randomized controlled trials, we're assured that those persons will be going through a systematic process to achieve defined outcomes, and the Y will be able to report those outcomes back to the partnering clinician. Lastly, and most importantly, is there has to be a way to sustain the model, because a program that can only reach 5, 10 people doesn't have true population health impact. So by identifying ways that the community-based organization demonstrates a value add to the healthcare partner and can integrate into a reimbursement model so it becomes a win-win for all. A win for the practice by getting access to extensive preventive health service and programs in the community, a sustainable model for the community-based organization, and ultimately more resources for better outcomes for the population upon which both are serving. And lastly, but not least, an ongoing partnership and evaluation where through this bidirectional information sharing, we may start with 1 or 2 programs and then identify that there are other programs. And the best models we've identified is where the YUSA has a suite of randomized controlled evidence-based programs, and then other locations have identified specific local programs that they can customize to meet the needs in their population, and then have a mix of the both so that they're able to really customize the services to the needs of the population upon which they're serving in alignment with physician practices that are undergoing transformation. This slide outlines the YMCA's model of community integrated health, and it includes everything from capacity building, where we're working closely with Ys to help them build the infrastructure to be an aggressive partner in communities to serve the population health needs, looking at health ways we can address health equity, shared spaces, compliance, and most importantly, implementing evidence-based interventions so that we can be assured that those consumers that sign up will achieve the goals that we define. This slide outlines the YMCA's portfolio of evidence-based programs. Each of these have undergone randomized controlled trials, and we support the implementation of these programs. YUSA supports the implementation of these programs throughout the movement of YMCAs across the country. The WISE evidence-based health programs support improving quality measures, and WISE can play an important role in supporting that, and whether those are supporting providers that are reporting ECQMs, MIPS, or alternative payment models. The way that works is WISE align their programs with the needs of the population. We identify those quality measures that the providers want to improve upon or need to report, and then as the consumers go through our programs, the information is captured, documented, and submitted back to the provider so that we're able to both be assured that we can provide that information. Most recently, YMCA of the UMCA has adopted Athena Health, or AthenaNet, as our health IT platform to support WISE across the country. And the first program that we've implemented under that model is the diabetes prevention program, so that infrastructure allows WISE across the country that have fully adopted and implemented that program to have a meaningful use certified platform upon which to document the information, receive referrals, submit information back to the provider so that they can see things such as the BMI on start, the BMI has changed over time, how that person has improved, barriers they've had, weight loss achieved. All of those measures can be identified. That data can be captured in the community where the consumer resides and then transmitted back to the provider and incorporated into their electronic health record. So other opportunities where YMCAs and other community-based organizations can begin impacting this performance categories are areas such as we implement various evidence-based fall prevention programs across the country, advancing care information, and improvement activities. So now I'd like to pass the baton over to my colleagues, Sally Sundar and Van Chaudhry of the University of Washington.
Thank you, Tim, and thank you for everyone for having us today. It's a pleasure to be on the webinar, and good morning from Seattle, where it's 10:15 a.m. To everyone here today. So my name is Van Chaudhry, and I'm glad to be joining to tell you a little bit about UW-Medicine's journey towards population care and how we stumbled very serendipitously with the YMCA, both on a deliberate side, but also excited to encounter all their work in the community on population care and really find a happy medium to work towards serving our patients within our health system and beyond. So I wanted to just start with a short brief background on what UW-Medicine is. As you can see in the picture, actually, if we don't mind going back one slide, Sally, thanks. We are a multi-system health system with 4 hospitals. Harborview is our safety net level 1 trauma center. For our city, we have also the UW Medical Center, which is our academic medical center for very large on cancer programs, and our cardiac center. Then 2 community hospitals, both Northwest Hospital and Valley Medical Center. So that really covers our 4 hospitals spread across the length and breadth of Seattle. And then underneath is our physician practice plan. We have the School of Medicine, a network of neighborhood clinics, 12 soon expanding to 14, and then our air ambulance program with Airlift Northwest. So we are an 8-entity system. We're also part of an accountable care network, which is, we're an anchor organization with 9 other partners, and are in contract with the Boeing program, the Boeing company, and started that contract 3 years ago. We're also in contract with various other payers and our local healthcare authority, the Washington State Healthcare Authority. So what's not depicted here is our clinically integrated accountable network. So essentially, UW-Medicine embarked on a journey towards population care around 3 years ago, and very much building on the model that Kindig started on population care, where if you think of 3 tiers, and if you will, 1.0 is truly acute, episodic, non-integrated health systems, really serving the patients within their own 4 walls. And then if you branch out a little bit further to 2.0, population health, that's more, to me, a coordinated health system, perhaps an accountable care network. There's a provider network of some kind. There's clinical integration efforts to align great outside of a hospital or a set of clinics to really integrate across your system. Maybe some shared financial risk, a focus on care management and preventative care, and really building a little bit more, in our case, outside of the health system, more into the accountable care network. And then if you think of the third and the last tier, this is really integration with community systems. And so here I think of a capability to integrate with community organizations like the Y, really thinking about populations and population-based reimbursement, value-based contracts, bundled payments, e-health capability, using different modalities outside of the face-to-face visit with a provider. You're exploiting telehealth and desktop medicine and phone visits and other modalities to really engage with your population. And so when we look at this 3-tier model, I think UW-Medicine really fits squarely, but somewhere between 2.0 and 3.0, where we're we have a great desire to partner and become a community integrated system, but we're still working on clinical integration and coordinating amongst our own system and within our accountable care setting. So that's sort of the lay of the land today. What was very exciting that brought us to the Y, we already had existing partnerships on referrals to the Y for their diabetes prevention, nationally renowned diabetes prevention program. And once population care became a part of sort of a real focus for us, thanks to the CMMI grant that we were awarded 2 years ago, and it really infused investment in areas we wanted to grow, we wanted to turn our attention towards building community partnerships and reinvesting in primary care, looking at how can we standardize and reduce unnecessary variation in practice. How do we move from caring from sick individuals to healthier populations, really promoting health prevention, chronic disease management, and how understanding that we can't do it all ourselves, so who could we leverage, who could we work with in our community that does a nice job already nationally, but also within the Seattle and Puget Sound area. And so our paths crossed with the YMCA and with their reputation of, I think there's a stat that I feel it was so impressive to us, that 80% of the U.S. population lives within a 5-mile radius of a YMCA. And given all the chronic disease focus on the Y, at the Y around diabetes and hypertension and weight management and depression or behavioral health, and ability to really optimize patients' activities and lifestyle choices and engaging with their healthcare providers, it just seemed like a really wonderful opportunity to partner further given the landscape we're in, moving from fee-for-service to fee-for-value. So that's sort of our story with how we began to work together. And Sally, if you want to advance. Thank you. We crossed paths and were able to start a dialogue which continues today, and I would say it's about 8 to 9 months old. So I'm going to hand over to my colleague, Sally.
Hey, thank you, Van, and thank you to the PCC Support and Alignment Network for having us here today. So as you've heard, as a YMCA, we're really here trying to impact population health through providing access to disease prevention and management programs in the places where people live, where they spend their time, and where they already have relationships. And so as a community provider, we look to our healthcare systems who are much larger, and in markets like Seattle, we have many large healthcare systems dominating the market. We look for them to give us opportunities to enter into this conversation and enter into discussions around how we can work together collaboratively, look to them to open those doors. So our goals around getting involved in clinical integration were really, how do we increase awareness of need in the at-risk population, knowing that the majority of people who are at risk for chronic diseases like diabetes are not aware of their risk, and how do we help those people find their way into our programs? And so for us, this really became possible by building off of existing relationships, like Van said. We had already been working with the UW Health Promotion Research Center, which is one of CDC's 26 health promotion research centers around the country. We've been working with them through our presence on their community advisory board. And that was really a setting where healthcare partners and community-based organizations like us were already coming together to explore how to find value in building community partnerships to better achieve population health goals. And part of what the Health Promotion Research Center was doing was conducting research around a couple of the WISE evidence-based programs and really showing the efficacy of those programs in creating and achieving target health outcomes. And so that gave us an opportunity to prove our program efficacy to that audience and make some connections to champions in the UW medical system there. Around the same time, we were working with the Washington State Public Employees Benefit Board, or PEB, to make our diabetes prevention program a covered benefit for state employees. So again, had a lot of momentum going around really building confidence in our programs and their ability to make wide-scale change. And our champion at PEB was also connected to our champion on the UW Health Promotion Research Center. And so they were involved together in building our state's first commercial accountable care organization, and really opened a door for us to build off of our relationships with them to come into these higher level conversations as a community provider. At the same time, again, we were working with a separate healthcare system, Virginia Mason Health System here in Seattle, and we had been involved with physicians and administrators in Virginia Mason around a Kaizen process to identify needs that providers will need for us to address in making them feel comfortable in sending patients outside of their doors into our community-based services. And so that had really built some confidence in our ability to respond to the true needs and true concerns of our healthcare partners. So all of this came together to create a lot of synergy around this idea of building community clinical linkages, and helped us really push forward with the referral network. It was really about having the right timing and right level of readiness on both sides of the conversation, and having champions that were embedded in these different institutions that could speak for the YMCA's ability as a community institution to reflect communities and serve communities and deliver on the outcomes that we say we can deliver through our evidence-based programming. And as Van said, we've moved forward from that referral conversation to really expand how we can work together in more innovative ways in the transition to value-based care. So moving forward of how we set up a clinic to community referral system. When we talk to providers as a YMCA, we present our entire suite of evidence-based programming, but we really look to the providers to figure out what are they most interested in focusing on. And most provider systems are more interested in starting out a bit smaller. So piloting referrals to just 1 or 2 programs, or perhaps to more programs, but only at 1 or 2 for the success that they see. And this makes it easier to implement these new processes and ways of thinking and doing in their clinics, and make the process of creating new workflows for providers a little more digestible. So with UW Medicine, we started with providers. We started by setting up a secure fax referral system. And so right now we're working with a grant from the YUSA and American Medical Association to set up a direct e-referral system between UW's EPIC EMR system and our Athena system here at the Y. But started by doing what we could do easily, which was setting up a secure fax system. And this is really where we work to build confidence in our providers of what we can do on our end to take care of their patients. So we have a very person-centered approach here at the Y. We will work with people to figure out where they're coming from, what their barriers are, what their goals are in terms of their health, their challenges and lifestyle needs that limit them from reaching those goals, and then figuring out what are they really ready for. So behavior change is a very intensive process, and being ready to get involved in behavior change programs like we offer here, for example, like our diabetes prevention program, those are big commitments, and they're long-term commitments. They last up to a year, and we don't want people to enter something that they're not ready for and will likely fail in and kind of add to their failure bank. We want them to be successful in whatever they commit to. So we participate in very extensive readiness to change conversations with our patients that are referred to us, and really get involved in a pretty structured care coordination process, figuring out exactly where they would fit, whether it's the referral that they were actually sent for or somewhere else, something else within the YMCA. And we actually encourage our providers to participate in a similar readiness to change conversation when they're discussing this option with their patients. We see that it leads to a much more higher rate of conversion into participation in one of our programs. So the next step is building provider education and awareness building. So we know that these health systems that we deal with are often very large. They have many different entities underneath them, and even when we've talked to people at the higher levels about creating agreements to refer people into our programs, it really takes us going and doing what we call our roadshow at these provider clinical sites and showing them what we do and how we support their patients and the health outcomes that we've seen and know that we'll see with their patients. And this truly increases the amount of referrals that we actually see. And I think it's building that face-to-face trust with the providers that is the key difference there. We work with providers to figure out exactly what communication needs they have and what will make them feel like they are keeping up to date on what their patient is experiencing. So we decide what health outcomes and updates they'd like to hear about and when, so that we can close that patient care loop or that communication loop with the provider. So we know that our providers like UW have confidence in our commitment that we reach out to people at least 3 times minimum, knowing that people can be hard to reach and they can be hesitant to get involved in these conversations that are difficult. We know that according to many health behavior change theories, on average, only 2 out of every 10 people will be ready to actually take on a lifestyle change commitment. So we work to figure out, what do we do with those other 8 out of 10 people? Where can they fit, and how do we make sure they don't fall through the cracks? Because here at the YMCA, we are person-centered and we're relationship-centered, and we want to make sure that we stick with people no matter what journey they're going to end up going on. And then we share information back with the providers at the midpoint and endpoint. If a patient does end up participating in a program, we keep them updated throughout that process of how that patient's doing and what health outcomes we have seen. This has become especially important, as Tim mentioned, with the new requirements around providers reporting different clinical quality measures. We know that they're going to want to have that information at their fingertips immediately and have that actually in the patient's EMR. So part of this e-referral grant that we're working on right now, again with YUSA and the AMA, is how can we actually set up electronic communication systems that allow us to get that patient data back into the provider's EMR quickly, so that they have that to refer back to easily. So Van, I will refer back to you to talk about how we are expanding this relationship past the referral process.
Thanks, Sally. So again, the basis of what we're excited about at UW Medicine is building on reinvesting in primary care and our desire to build a patient-centered medical home, or actualize that, and of course extend into community partnerships, as well as then figure out which other areas does it make sense from a specialty, from a tertiary, from a quaternary care view to also extend community partnerships as a vehicle to care for our patients. So some of the opportunities front and center for us as we encourage our primary care providers to become more familiar with their panels. So each of our PCPs or primary care providers have panels of their slice of the subpopulation that they're accountable to treat with the primary care teams that support them. And so encouraging them to understand what's the current state of their panel in terms of opportunities to improve health outcomes, keep their patients healthy out of the hospital, focused on chronic disease management and ensuring that patients have the tools and are engaged and can participate in their healthcare in settings that they want to be in, which is not necessarily in a clinic or in a hospital, but in the community. So creating linkages there, but also looking at what other programs would benefit from a community partner. And so in addition to chronic disease management and the behavioral health services and some of those basic care gaps I talked about around hypertension or depression or monitoring diabetes or pre-diabetes, there's also an opportunity to look in the musculoskeletal space around joint surgery, and for those patients that elect to have a hip replacement or a knee replacement or say a lumbar fusion surgery, how could we partner with the YMCA, for example, to optimize patients' readiness for surgery so that before surgery they're in the best state of health in terms of their function, their activity, perhaps if they have diabetes that there's control with their blood sugar, their weight is under some level of control, so that once we have the surgery we're optimizing them for the best outcomes and putting them on a path to easeful and quick recovery. And so looking at bundled payments coming down the musculoskeletal, in the musculoskeletal world around hip and knee and spinal fusion surgeries. Integrating and looking at ways of incorporating these sorts of models within UW Medicine as a health system, but also beyond our 4 walls into our accountable care network. Also, we're a part of a WWAMI, a 5-state WWAMI PTN, or Practice Transformation Network. And so our population care vision starts within UW Medicine as a health system, but also looks at very quickly trying to improve outcomes on various value-based contracts, say with Boeing and with the Washington State Healthcare Authority with our PEP patients, and also beyond within our outside into the WME, our 5-state PTN. I talked a bit about chronic care management. This is truly around enabling providers to partner with their patients around self-management, engagement, patient activation on managing hypertension and their blood pressure, making sure that's under control. If they have depression, how do we make sure they feel that they can participate in a way that enables them and allows the various severity of patients with depression to engage with their healthcare team and with their community team. Managing activity levels, weight, lifestyle choices, whether it's as simple as diet and how to eat better, how to exercise more, it might be learning how to do self-monitoring on blood pressure, or making sure that pre-diabetes patients don't get worse and become diabetes patients with high hemoglobin A1C levels that are out of control and trending in the wrong direction. So I would say from the angle of primary care, which is where we want to make sure our patients it's our door into our system, into our accountable care network. It's where we want patients to engage, but also stay healthy out of the hospital, to bundled payments around joint and spine surgery and future bundled payments. We're excited about exploring this partnership further within those sort of two domains.
Thank you, Gan. I would just add that one of the other pluses of working with the Y is, in general, we can be pretty flexible and innovative in our response to the needs identified by our healthcare partners. So, for example, in a recent conversation with the post-acute care team at UW, we talked about how there's a need to have somewhere to send patients to deal with pain management that's not going to rely simply on prescribing them a medication. And so we've talked about here, well, how can we build a chronic pain self-management class? You know, we're licensed to lead Stanford evidence-based programs like their chronic pain self-management class. And so really, for us, being able to respond pretty flexibly and quickly to the needs identified by our partners as those come up. So moving forward, just to talk about some of the challenges and opportunities that we've experienced throughout this process, there's definitely a lot of competing demands in the healthcare system, and I'm sure many people on the call are well aware that there's so much change happening and so much being demanded of the healthcare system right now that there's only so much that one system can focus on at one time in terms of change. And so even when we get a lot of positive response and energy around this opportunity to work together, things just can't always move quickly on the provider side because there's so much happening at one time. And so that's to keep in mind when working with healthcare partners during these transition periods. We also see a hesitancy to send patients outside of the four walls of the clinic. So even though many health systems are definitely open and willing to try new approaches to population health care and are recognizing that clinical care really only accounts for up to 20% of the determinants that influence someone's health outcomes, and that the other 80% of what influences their health outcomes exists in the rest of their lives and out in the community, and that's why we need community partners involved. It's I think it's just easier sometimes for healthcare systems to attempt to do new things in-house rather than taking advantage of existing opportunities or existing programs or relationships in the community. And so for us as a community-based organization, it's just trying to push that confidence in what we can do and confidence in sharing that accountability for what happens to the patient's health outcomes. We also see a really widespread lack of coverage for wellness services. So a lot of people don't have access to services like the diabetes prevention program or blood pressure self-management or whatever else it is through their insurance coverage. And a lot of times they're having to pay out of pocket, and that's a huge limitation for the patient. And so as a nonprofit, we as a Y will never turn anyone away for inability to pay. We will always make something work so that they can take advantage, especially if they're ready to make some real lifestyle change around their health. But in terms of program sustainability, we have to make sure that we're able to continually offer these programs in all of our locations, and that means that we need to be finding new reimbursement pathways to cover participation. And so that's definitely also can be a barrier to these types of community clinical linkages. And finally, there's a need for ongoing provider education around this work. There's staff turnover in healthcare centers. There's, again, a lot of competing priorities, and so it's not just a one and done, go and educate the providers and know that everything will go from there. It really takes a lot of ongoing communication between the healthcare system and the community-based organization. So between us, the YMCA, and our partners at UW, it's a lot of ongoing conversation, and that just needs to have staff time put aside to make sure that they're devoting enough time and attention to that continued relationship building.
Thanks, Sally. So I will just reinforce that Sally touched on this. UW Medicine is no different from several other health systems across the country that are facing a change in payer mix, that are facing declining reimbursement rates over time, that are facing a need to be nimble and flexible in moving from fee-for-service compensation models for providers to fee-for-value and moving towards performing in value-based contracts. And this has been a challenging budget year for UW Medicine as a system too. So given those, the current state landscape, what is our approach to still reinvesting where we see the future going, which is around partnering with the community and really moving the needle towards that 3.0 tier of community integrated partnerships. So for us, my role is really being an evangelist as an internal leader on population care and evangelizing, socializing, increasing awareness wherever I see opportunities within different service lines around the YMCA as a willing partner to explore whether it's starting small, where there are synergies with existing priorities and the ambulatory space around improving the health of our pre-diabetes patients and making sure that they don't get worse and end up with full-blown diabetes, or if somebody does have diabetes, how do we ensure that they're cared for in a setting that they want to engage in? And so raising the awareness around chronic disease programs in health and wellness, programs that the Y offers, raising awareness around opportunities with specialist providers to optimize patients before surgeries, like I described. So being an evangelist and putting forward very judiciously opportunities within the organization as they arise to talk about that we don't have to do it all on our own, and there is a way to be nimble and partner with community agencies like the Y. I think what's really key is a common denominator in all this exploration is finding a sustainable framework and testing starting small before full scale and spread, and having an evaluation framework to say, if we started and piloted a particular program, say like the e-referrals, we're super excited about doing that at one of our network clinics. What does that look like 3 months after it goes live, and is it working? What are our outcomes? Are we ready to scale and expand? And how does this fit with our overall sense of priorities and goals for population health? It is all about achieving the triple aim, so better health at a reduced cost and in a way that quality outcomes are maximized and in a way that patients and providers are satisfied. I think this is key. So everything we do should have a lens that there is a value proposition behind it, and that we're doing the right thing for our patients, and in a way that allows us to really extend our services in a way that makes us look forward and integrate with community partners. And I think a key piece that we're excited about is being able to measure that. So we internally have a pretty robust way of, and we have a lot of business intelligence platforms that we are now able to use to see where are there opportunities to improve our patients' health in the primary care space. How are we doing on our HEDIS quality measures? And so then being able to leverage that information and create targeted, specific, focused interventions that allow us to improve those outcomes. So like in the diabetes and pre-diabetes space, in the joint surgery space, in the behavioral health and hypertension quality measure space. So Sally, over to you. Oh, it is me. Thank you. So I would say in summary, we're at this precipice or at this cusp at UW Medicine where the partnership with the YMCA has started. We've had it for many years and now it's formally recognized. And there's a lot of enthusiasm and willingness and I would say excitement about moving forward, testing new programs, starting small and making sure that it's working and scaling and spreading as needed. In 2017, we're excited about piloting the e-referrals with the diabetes prevention program. We're thinking of 1 or 2 clinics, and then as I said, we'll be watching how that works. And I think part of it is also building relationships with providers and being able to socialize and evangelize as you start something, the outcomes and the positive, reinforcing that look how this is working and would you be willing to try, and then having that be also a way to scale and spread with finding clinical champions that are willing to try and test. We're also beginning conversations with our surgeons. Actually, the conversations have begun. There's a lot of excitement around testing, partnering with the Y on optimizing patients before joint surgery, before spine surgery, and managing them to a point, enabling them to work their health status to a point so that they're at the best place to have surgery so that the outcomes are maximized, whether that's optimizing their activity, getting them on an exercise program, making sure their blood sugar is controlled, their diet is in a way that allows them to eat well and manage their lifestyle. So we're excited, I think, in continuing these opportunities within primary care and then in the musculoskeletal space. So I believe, Sally, this was our last slide, if I'm not wrong.
We have one more. So just some key takeaways on how to get started in building these community clinical linkages for anyone on the line who's looking to get involved in this type of work. So first, I think it's just about being willing as a system to go outside of your walls and embrace other organizations that are active out there and serving the community and are committed to the community's well-being and population health. Identifying champions both in the healthcare setting and in the community-based setting. So this is, as we've said, this is a new way of doing things, and you really need individuals who are willing to champion the work internally. And we've definitely seen, you know, at UW, for example, specific providers or people on the administrative side like Van who have, as she said, evangelized this work internally and pushed it forward. So making sure that you have those champions who are willing to shoulder this and push it forward in both settings. And then identifying the low-hanging fruit where priorities in each organization align. So with the healthcare system, figuring out what are some gaps in care or gaps in health outcomes. These could be determined by different performance metrics or major cost drivers or other patient health outcome data, but figure out where is there a gap that we would like to be addressing better as a healthcare system, whether that's conditions related to obesity or to diabetes. I think especially if there's some acknowledgement of the social side of those conditions and how those get exacerbated, and that's an easy way to make some ties to what community-based organizations like the YMCA offer and how those match the gaps within the healthcare system. Looking into the internal processes and logistics that need to be set up to move this work forward. For example, before we can share any patient data, we have to have a business associates agreement in place. IT-wise, we're still working on how do we best have our EMR systems talk to each other, and then workflows, how do we make it easy for providers to easily refer patients to the YMCA program so that it's not going to disrupt their limited time that they already have with the patient. Again, pursuing provider education and awareness building, knowing that that familiarity and trust in the external resources like we offer at the Y are going to be key first steps to getting providers on board and actually utilizing the referral mechanism that gets set up. Tracking patient utilization of these services and health outcomes, so always sharing back between the CBO, the community-based organization, and the healthcare system, which referrals are actually being taken advantage of and what's happening to the patients that are in those programs. Again, communicating patient data back to the provider. So as Van mentioned, we want to be able to define our value proposition to the healthcare system of what these community-based services offer. And so, for example, we've put together a specific performance metric tool where we've outlined under MIPS and under accountable care organizations and other performance metric requirements, how do our specific programs actually support and speak to very specific performance metrics that we see within those different models. Evaluating and revising the process continuously, lastly, is really important. The healthcare field is changing so rapidly, and there's a lot of new policies and new technology that shift and that open or change certain opportunities, and so making sure that our opportunities for collaboration are taken advantage of and that they grow or shift over time in response to this changing context is really important, and making sure that both sides are really active and being on top of that process. And just most importantly, I think in all of these steps, the most important thing is to have a dialogue going and a relationship built between the healthcare system and the community and major community providers like the YMCA, and knowing that providers shouldn't be hesitant to ask how their community-based partners can help them and how they can be flexible and really work in the relationships they already have to better extend the goals of clinical care into the community. So I think we're ready for some questions.
Well, thank you so much. We do have several questions, so I'll jump right in. So first, so for medical care being provided by non-clinicians in the community centers or like in the YMCA setting, how does one go about managing that? So if someone is coming in and they're wanting to get assistance with monitoring blood pressure or anything like that, if there's a non-clinician in the Y, how would one go about providing, I guess, medical care if that's not necessarily their field? Is there someone in the center that could help, or do you guys bring in trained clinicians to assist with the groups there, or how does that work? I think that will probably go to Tim.
Great, that's an excellent question. Many people may be surprised to know that several across the country actually have some aspects of clinical staff that work inside their Ys. So many YMCAs have things such as registered dietitians. They have exercise physiologists. They have diabetes educators. And so, and they brought those persons on board to better meet the needs of serving the population health. In addition to that, some of our evidence-based program models, such as the diabetes prevention program, we have trained health coaches that undergo a rigorous training curriculum prior to being able to serve in that role. And one of the aspects of that training is to recognize when there are issues and concerns that the consumer presents with that beyond the scope of the trained health coach, and then they refer that person on to a clinician that can provide better support. And then lastly, I just want to highlight the fact that each of the best models we are those where there's really full clinical integration between the YMCA and the clinical practice. So we've talked about this bi-directional referral process. So now if the person may see a registered dietitian at the Seattle Y and there's problems identified, that dietitian has direct access to the University of Washington clinics and the providers there so that both can fully support that consumer to the highest level of their scope of practice.
Excellent. Sally, did you want to add something to that?
Yes, I would just add that these evidence-based programs that we offer here at the Y, the research around them is conducted in such a way to ensure that, for the most part, that lay providers can be as effective in delivering these programs as they would be delivered in a clinical space. So it's always in the evidence basis, and that these studies have been translated into YMCA settings to ensure that even if we do not have a clinical presence on site, that these programs will be as effective in delivering the patient health outcomes that we want to see. And I would just add that there's definitely growing opportunities, as Tim said, to really integrate the communication between the clinicians and between YMCA staff. And so, for example, when we a few slides ago talked about outsourcing chronic care management services to the Y, that's an opportunity for someone at the Y to really invest and work closely with somebody around their chronic care management needs, but always have that line of communication open with the physician or the clinical care team to make sure that any kind of medical-related need that requires a medical presence or medical supervision is addressed. And we would never pretend here at the Y to have a medical expertise that we don't, so we would always be very reactive to referring people back to their clinical care team when necessary.
One last thing that I want to highlight what Sally just said. One aspect of that is around when Sally talked about kind of the person-centered planning that the Y does and ensuring that the person is motivated for change and is going to the appropriate program. Well, part of that person-centered planning and the communication with the provider, they're essentially operating under general supervision with the clinician that referred the consumer, and then when there are changes, additional information, then that's submitted back to the provider. And that's a similar model to the chronic care management benefit, where there's a overall person-centered plan, there's trained health coaches in the community that are supporting the delivery of that plan under general supervision of the clinician.
Excellent. So there's another question. Are there any of the MCOs involved? So there's a MCO from Louisiana, and they're interested in reaching out to the YMCA for additional resources.
So we have engaged multiple MCOs or managed care organizations across the country, and we have many of them that are currently reimbursing for our diabetes prevention program, and others that are looking for different programs that are available at their local YMCAs. And it really spans the range of our evidence-based suite of programs. And so that is absolutely something that we encourage and support, and that YUSA even work in building capacity of local Ys to better meet the needs of MCOs when the MCOs have identified interests.
Great, and I remember, I think your that email address was in a previous slide, so we'll definitely have the slides available online so everyone has access and will be able to contact Tim and his team about additional resources. So Tim, again, there's another question about you guys being connected to Athena Health. Is that, I don't recall, is that fully implemented for all the YMCAs to use, particularly for your DPP program? And is that the intent to use for all of the Y programs across their clinic partnerships?
So that's an excellent question. So it is fully implemented for our diabetes prevention program and currently operating nationwide. And so if the local Y is fully implemented in DPP and have met, or diabetes prevention program and have met all of the requirements and have, they also have to undergo HIPAA training and other things. If they've met all those requirements, then yes, they have full access to the Athena system to support DPP. And we're systematically bringing more of the YMCA's national platform of evidence-based programs online with Athena Health, so we'll be able to support Ys across the country in delivering all of these evidence-based programs through one unified platform and being able to provide things such as claims management, processing, outcome reporting, and other things through this unified national AthenaNet platform.
Great. And just to piggyback off that, do you guys have any telehealth programs that the YMCA or even the University of Washington is trying to implement right now?
So I can speak for YUSA. So currently, right now, all of our programs are really in-person programs. There are some Ys that are testing telehealth service models with clinical partners. For example, I know the Charlotte Y is testing that with Carolina's health system, but we don't have a national program for telehealth at this time, but definitely supporting the adoption of telehealth in specific markets where the clinicians and the community have requested it.
Great. And there's another question about getting access. So you have the Athena Health system set up, but and before that, was it difficult, or actually while you're implementing it, is it difficult to still receive data from healthcare organizations? And do you receive, did you have to have like a similar EHR in addition to the Athena Health? What's the challenges, or are there any challenges in receiving data or processing data back and forth from the Ys to the practices?
So in terms of integration of IT systems, so anyone who's adopted the major IT platforms know that those things don't just turn on a dime, and it's just not a flip of a switch, and then you're automatically sharing data. So hopefully we'll get to that one day, but right now it's not there. And so what occurs is, at least with our diabetes prevention program, which we've launched fully through Athena, we're working to identify the best practices upon which we can have bidirectional data exchange with all the major platforms. So obviously, since we're already on Athena, anybody else is on Athena, that infrastructure is already there. We're currently working to see how we could have seamless integration with all of the other major systems such as Epic and Cerner and others that are prolific within the marketplace. And we're testing that in markets where we have very progressive thinking and operating YMCAs and clinical partners, such as in Seattle with the University of Washington and the YMCA of Greater Seattle, and then adopting what has worked there in those other markets.
Great. So we have a lot of questions, but we'll follow up with everyone who had a question via email. But this was a very, very engaging webinar, and I personally learned a lot, and very interesting to know that there are effective partnerships going on with communities and their practices. So that's wonderful to know and to follow up on. So we're at the top of the hour, and so this will conclude today's webinar. But again, please feel free to contact us if you have any additional questions. We're more than happy to answer them via email. But again, the webinar recording and the presentation slides will be available on our website by tomorrow afternoon. So you'll be able to access this information and share it with those who weren't able to attend today using that link. So thank you, and we're very, very honored to have Van and Sally join us, and thank you again, Tim, from the YMCA, for presenting this wonderful webinar today. So thank you, and everyone, please have a great rest of your day.
Thank you. Have a great day.